Hello, I am Martin Lederman, co-founder of the organization One World, One Vision. Over a decade ago, my associate and I, while on a surgical mission to Belize, founded One World, One Vision in order to train local ophthalmologists and, by doing this, extend our reach. We were successful, and since then, our organization has gone to multiple countries and have demonstrated the success of our ideas. We added anesthesiologists and pediatric intensivists to the mission in order to train local physicians and make the surgical experience of our patients safer. Since then, we have realized that the paradigm of one patient, one student, and one surgeon, while successful, could not begin to address the need. There are tens of millions of children and adults with strabismus and amblyopia. We decided, therefore, to support and to promote a video course in strabismus and amblyopia and approached Dr. Bert Kushner to develop a curriculum and to recruit worldwide experts to give lectures. We stipulated that the course should be translated into multiple languages and to be distributed without cost around the world to eye surgeons. We are particularly grateful to our former patients and friends who have given the financial support to make our dream a reality. We are delighted that Dr. Kushner has accepted the challenge, and we hope you find the lectures both stimulating and educational, and that you share them with your colleagues and your students. And so, without further ado, I give you Dr. Bert Kushner.
I want to welcome all of the viewers to this lecture on oblique muscle surgery as part of the One World, One Vision comprehensive course on strabismus. If you're a prior viewer of this series, I want to welcome you back. If you're new to this series, I'm glad that you're here. I'm Bert Kushner, and I'm the moderator of this lecture series. And we are particularly fortunate today, and I'm so pleased to introduce our speaker, Dr. Federico Velez, who will speak to us on oblique muscle surgery. Dr. Velez is the Leonard Endowed Chair of Pediatric Ophthalmology at UCLA, Jules Stein, and the Doheny Institute. He's the associate editor of the Journal of AAPOS, and he's the medical editor of the World Society of Pediatric Ophthalmology and Strabismus newsletter. He chairs the AAPOS Adult Strabismus Committee, and he's a member of the American Academy of Ophthalmology Program Committee. Dr. Velez has presented over 400 national and international lectures, including 5 name lectures, and he has over 250 articles that he has published. He's won the UCLA Jules Stein Institute Best Teaching Award. His particular research interests include the medical management of thyroid eye disease, the binocular treatment of amblyopia, artificial muscle stimulation, and the use of plasma-rich growth factor in preventing ocular muscle fibrosis. You'll see why he has so many accolades when you hear his talk. I'm sure you're going to enjoy it as much as I will.
Thank you, Dr. Kushner. It is a real pleasure and an honor to be here with all of you and all the colleagues around the world. I want to thank the One World, One Vision organization for inviting me to present this lecture on surgery of the oblique muscles. We're going to divide this lecture on superior oblique and inferior oblique. We're going to start this lecture on superior oblique under action. This condition is characterized by a hypertropia, a V pattern, and extortion. Regarding the hypertropia, it is very important to determine which field of action is affected by the superior oblique under action. Is the field of action of the ipsilateral inferior oblique, so the deviation will be worse in contralateral adduction elevation, or is the field of action of the affected superior oblique. The deviation will be worse in adduction and infraduction corresponding to the field of action of the affected superior oblique. Is the deviation commitant or incomitant? Most of the commitant deviations are related to long-standing superior oblique underaction associated to ipsilateral superior rectus muscle contracture. The deviations that are incomitant are usually worse in the field of action either of the inferior oblique or the superior oblique muscles. They're worse in contralateral cases. The V pattern may be caused by a superior oblique underaction in down gaze and is manifested by a V pattern esotropia in down gaze. But there are patients that will present with an exotropia in up gaze caused by an inferior oblique overaction in elevation. Oblique is an intortor. When the muscle is underacting, patients will present with excyclorotation of the macula relative to the optic nerve. Patients with superior oblique underaction frequently will have a positive head tilt test with an increase of the hypertropia when the head is tilted towards the affected side of the superior oblique underaction. This picture depicts the right hypertropia that is decreased when the patient is tilting the head towards the left. Grading the superior oblique underaction based on a scale 0 to -4 will correspond to the amount of downward rotation in the field of examination of the superior oblique. This corresponds to the position in adduction because the superior oblique tendon will align with the visual axis of the eye. And this axis, when aligned the superior oblique, will allow the examiner to determine the vertical function of the superior oblique, much easier to determine if the muscle has normal action or is an underacting muscle. The top picture depicts a patient with a mild under depression in adduction. The middle picture depicts a more significant under depression in adduction, and the more severe will be a -3, which is the bottom picture demonstrated significant under depression in adduction. On this picture, you see a patient who had no down gaze rotation in the field of action of the superior oblique. And this video will demonstrate that when the patient looks to the right, has very good ocular rotation, excellent elevation. When the patient looks to the left, there is a significant under depression with a hypertropia of the right eye in adduction. This is what I call a -4 superior oblique underaction. This picture demonstrates a patient that has a chin down position, and looking in up gaze, the patient has single vision. This is a common pattern on patients with bilateral superior oblique palsy. This video demonstrates a patient that has very good rotations to the right with good elevation in all fields, good rotations to the left, and when the patient looks in down gaze, you're going to see a significant V pattern esotropia with significant under depression of the left eye in adduction and more significant the right eye in adduction. This is a patient with bilateral superior oblique palsy. I'm going to use a classification that is not frequently used nowadays, but is actually very important when you are approaching a surgical patient with superior oblique underaction. It's the NAP classification for superior oblique palsy. And it's very helpful. So we're going to assume that a patient has a monocular or unilateral left superior oblique underaction. So the class 1 classification depicts a patient that has a hypertropia that is worse in the field of action of the ipsilateral inferior oblique muscle. This patient will be treated by weakening that inferior oblique. The class 2 is the patient that has a more significant deviation, hypertropia, in the field of action of the ipsilateral affected superior oblique. The most frequent procedure performed for this patient is a superior oblique strengthening procedure. We're going to refer to these procedures later in this lecture. You could consider also surgery on the contralateral inferior rectus muscle. The class 3 is the patient that has a significant hypertropia in all contralateral adducting fields. And the patient will have a significant hypertropia in the field of action of the inferior oblique and the superior oblique. In general, depending on the degree of deviation this patient has in this field, the patient may be treated with a superior oblique strengthening procedure like a superior oblique tuck. And if the deviation is very large, more than 25 prism diopters, it's recommended to add another muscle, in this case, an inferior oblique weakening procedure. Class 4 is the patient that has a significant deviation, not only in all fields of adduction, but also in all fields of down gaze. So this deviation, depending what is significantly worse, can be treated by straightening the superior oblique. If the deviation is larger than 25 prism diopters, including an inferior oblique, and an additional procedure could be strengthening the inferior rectus. An alternative procedure may be an inferior rectus muscle recession on the contralateral eye as well. When you start seeing patients that have more concomitant deviations like this one, could be associated to an ipsilateral superior rectus muscle contracture. However, those patients will frequently have a significant deviation in the ipsilateral field of gaze. In this case, will correspond to the deviation in the left gaze, to those two rectangles that do not depict any white color, which actually demonstrated no deviation in this class 4, but it will be demonstrated on a patient with superior oblique palsy and ipsilateral superior rectus muscle contracture. The patient with class 5, similar to class 4, will have a significant deviation in down gaze, but will have no deviation in the field of action of the ipsilateral superior inferior oblique muscle. These patients can be treated depending on the concomitant by operating the superior oblique with a superior oblique strengthening procedure, an inferior rectus strengthening, or preferably a contralateral inferior rectus muscle recession. The class 6 is the patient with bilateral superior oblique palsy. And this is really important because the patient with bilateral superior oblique palsy clinically should have what is called a reverse hypertropia. Those patients will have a superior oblique underaction that will be only manifested by a reverse hypertropia depicted by a right hypertropia in left gaze and left hypertropia in right gaze. It could be only present in the field of action of the superior obliques. There are some criteria that will suggest a patient having a bilateral superior oblique palsy, large amount of extorsion, more than 10 degrees, a large V pattern. The treatment of choice depends on where the deviation is worse. It could be bilateral inferior oblique muscle weakening procedures, bilateral superior oblique strengthening procedures, or a bilateral inferior rectus muscle recession, which can be performed under adjustable suture and is a procedure that can not only correct the vertical misalignment, but because the inferior rectus are adductors and also extorters, it can improve the V pattern isotropy in down gaze and the extortion in down gaze. The class 7 is a very unique condition that combines a superior oblique underaction in adduction, like a superior oblique palsy, but is associated to a patient that has significant limitation to elevation in adduction, similar to what is seen in a patient with Brown syndrome. This is also being called the canine tooth superior oblique palsy, but it can be also present after orbital trauma or surgery. So these patients will have a hypotropia in elevation in adduction and hypertropia in downgaze in adduction. Now we're going to move to superior oblique overaction. And the superior oblique overaction is also characterized by a pattern of vertical deviation, in this case, hypotropia. The patient will present with an A pattern and intorsion. The hypotropia is characterized by a larger degree of hypotropia in adduction corresponding to the field of action of the superior oblique muscle. If the patient has a larger deviation in elevation in adduction, because the superior oblique muscle is tight, the patient will have a pattern similar to a Brown syndrome, or the patient can have a pattern similar to an inferior oblique paresis. To make the differential diagnosis, the forced head tilt test, a forced adduction test, the presence of an A or V pattern, and the presence of torsion can help with the final diagnosis. Patients with superior oblique overaction will have an A pattern, either characterized by an esotropia in upgaze or an exotropia in downgaze. When the patients have a limited elevation in adduction because the superior oblique is overacting, it is also important to determine if the patient has an A pattern or a V pattern, because if the inferior oblique is weak or the superior oblique is overacting, the patients will have an A pattern. But if the patient has a Brown syndrome, which actually will be characterized by a limited elevation in adduction, the patients will have a V pattern in upgaze. Intorsion is typical for patients with superior oblique overaction and also for patients with inferior oblique paresis, not in patients with Brown syndrome. This picture depicts a patient with a large angle exotropia in downgaze caused by superior oblique overaction. Grading the superior oblique overaction from the scale 0 to +4 is demonstrated by an overdepression in adduction. The top picture demonstrates a patient with mild overdepression in adduction of the left eye. The middle picture depicts a more significant overdepression in adduction of the right eye. And the bottom picture demonstrates very significant overdepression in adduction in a patient with Graves' disease and severe superior oblique overaction. This is a patient with bilateral overdepressions in adduction, more severe on the left eye than the right eye. We're going to move to the inferior oblique muscle. And we're going to start with superior oblique underaction. Inferior oblique underaction is characterized by a hypotropia in the field of action of the inferior oblique. It is very important to evaluate the pattern. If a patient has an A pattern, it's very likely that the patient has an inferior oblique underaction with a superior oblique overaction. However, if the patient cannot elevate the eye in adduction and the patient has a V pattern, it is very likely that there is a restriction to elevation in adduction caused by a Brown syndrome. The patients with inferior oblique underaction will also have a positive head tilt test. This picture is characterized by demonstrated mild bilateral superior oblique overactions in downgaze, and in the left eye, you see a limited elevation in adduction. So this patient has a weak inferior oblique with a limited elevation in adduction and an A-pattern exotropia. The patients with inferior oblique underaction will demonstrate torsion on fundus examination. Last, it's very important to perform a force adduction testing to determine if the limitation to elevation in adduction is caused by restriction, as seen in Brown syndrome, or by paresis, as seen in patients with true inferior oblique underaction. Grading the inferior oblique underaction on the scale 0 to -4 is demonstrated on the top picture here with a limited elevation of the left eye in adduction of -2.5 and a very severe limitation to elevation in adduction of -3 at the bottom picture. Inferior oblique overaction. So the patients with inferior oblique overaction have a hypertropia in the field of action of the inferior oblique. It's also very common for patients with superior oblique palsy to present with an inferior oblique overaction and a hypertropia in the field of action of the inferior oblique, as we demonstrated earlier in this lecture on the class 1 NAP classification of superior oblique palsy. The patients with inferior oblique overaction also will present with V pattern, exotropia in up gaze, or if they're limiting significantly the superior oblique function in down gaze, or the primary cause of the inferior oblique overaction is a superior oblique palsy, the patient will present with an esotropia in down gaze. The most common torsional component of an inferior oblique overaction is excyclotorsion. The patient will present with a hypertropia that is worse in adduction in the field of action of the inferior oblique, as depicted on this picture, with a significant over-elevation in adduction when the patient is looking straight and left gaze. This patient has an exotropia in up gaze caused by bilateral inferior oblique overaction, and graded the inferior oblique overaction, as is depicted on this picture, demonstrate mild overaction +1 on the top picture, moderate, second picture from the top. The third picture from the top demonstrates a very significant over-elevation in adduction of the right eye, and the last picture at the bottom demonstrates not only a significant over-elevation, but also an abducting movement of the left eye in abtented elevation. You may also see that this patient has some slanting of the palpebral fissures. This is important because there are patients that will have a significant pattern that can be associated to orbital anatomy disorders. Now we're going to move to surgical techniques. And we're going to start with the inferior oblique muscle. Inferior oblique weakening procedures include recessions, myectomy, anterior transposition, nasal transposition, nasal myectomy, periosteal insertion or fixation, and denervation extirpation. Surgery is indicated for patients with hypertropia in the primary position, significant V pattern with exotropia in up gaze, patients with significant hypertropia in lateral gazes, and also for patients with torsional diplopia caused by excyclotropia. The indications for an inferior oblique recession, which is a minor or moderate weakening procedure, includes mild to moderate inferior oblique over elevation in adduction up to plus 2.5 on a scale 0 to 4, patients with excyclotorsion, and patients with concomitant hypertropia that is worse in the field of action of the inferior oblique muscle. The incision may be performed by rotating the eye in elevation in adduction, creating a conjunctival fornix incision approximately 10 millimeters posterior to the limbus on a fornix fashion running between the inferior rectus muscle and the lateral rectus muscle. A blunt dissection is desirable to prevent any exposure of the orbital fat, and this maneuver using forceps retrieving the posterior tenons to expose the belly of the inferior oblique is very helpful. When the belly of the inferior oblique is observed, the muscle hook is placed to retrieve the more posterior and anterior fibers of the inferior oblique belly. This maneuver may be repeated several times until all the most posterior fibers are isolated on the muscle hook. It is also important to visualize the exposed orbital fat and to avoid opening the orbital septum to prevent the exposure of the orbital fat to prevent a complication caused by fibrosis and scar tissue formation. Another method to weaken the inferior oblique and expose the inferior oblique is depicted in this video. Again, a conjunctival incision is created on the fornix, blunt dissection, and with the help of two muscle hooks, the inferior rectus muscle is isolated, the lateral rectus muscle is isolated, and a retractor is placed on the inferotemporal fornix to expose the belly of the inferior oblique. The surgeon must be aware as well that the vortex veins are very close to this inferotemporal quadrant. A clamp may be used when the inferior oblique is isolated. It's actually very helpful because it may help with the control of the bleeding. It is important to do good hemostasis before the inferior oblique muscle is disinserted. I personally recommend using a single arm absorbable suture. The reason I prefer this is to prevent creating an anti-elevation syndrome, something we're going to be referring as a complication in a few minutes. The muscle is recessed, and I'm going to explain how the muscle is recessed. I measure a distance from the temporal corner of the insertion of the inferior rectus muscle posteriorly, 4 to 5 millimeters. That position corresponds to a 14 millimeter recession of the inferior oblique muscle. Each millimeter temporal decreases the amount of recession by 1 millimeter. So for example, if I measure 5 millimeters posterior to the temporal corner of the insertion of the inferior rectus and 2 millimeters temporal from that point, I've recessed the inferior oblique 12 millimeters. The muscle is secured on the sclera with one single arm absorbable suture. This procedure that I'm going to present here is very helpful when patients have very small deviations in the primary position. It's a procedure known as a Z-lengthening partial width myotomies. The method I use to perform this procedure includes placing marks on the inferior oblique belly, extending from the muscle insertion. The muscle insertion, you can see it because it's already marked and it's isolated on a muscle hook. It's next to the lateral rectus that is also isolated on another muscle hook. And I place marks separated by 1 millimeter. I carefully cauterize to decrease bleeding. As you know, the inferior oblique is a muscle with a very short tendon and has the tendency to bleed significantly when an incision is made. So I cauterize and then I place cuts on opposite sides. Each of these cuts is separated by those marks 1 millimeter, and each cut corresponds to 50% of the inferior oblique muscle width. What this creates is a controlled elongation of the inferior oblique muscle that is very helpful to manage a small deviation. On my tables, each incision corrects approximately 1 diopter of vertical hypertropia in the primary position. When the patient has more than 5 or 6 prism diopters of hypertropia in the primary position, I personally prefer to do a recession procedure following the technique that was presented on the previous slide. Anterior transposition, I reserve this procedure for patients with more severe inferior oblique overaction. When I say more severe, are patients with more than +2 of inferior oblique overaction on the scale 0 to +4. I also reserve this procedure for patients with dissociated vertical deviation that present with an concomitant deviation. The patients with dissociated vertical deviation, they have a deviation that is worse in the opposite gaze in the field of action of the inferior oblique will benefit from weakening the inferior oblique. And the most common performed procedure is a weakening that is anterior to the line of the path of the inferior oblique. In other words, the inferior oblique is anteriorly transposed, and there are different degrees. Some people call it station 0 when the inferior oblique is reinserted at the level of the temporal corner of the insertion of the inferior rectus. Each millimeter posterior is considered as a -1, -2, -3 position for the anterior transposition. It is very important when an inferior oblique is transposed anteriorly to prevent an inferior oblique causing an anti-elevation syndrome. This anti-elevation syndrome is being well described by other authors such as Mims, Kushner, and Kraft. And the most common causes for an anti-elevation syndrome include spreading the inferior oblique temporal to the inferior rectus muscle insertion more than 2 millimeters away, spreading the new insertion of the inferior oblique more than 2 millimeters if a double arm suture is used, or placing the anterior transposition anterior to the insertion of the inferior rectus muscle. A nasal anterior transposition of the inferior oblique is considered as a more significant weakening procedure. The new insertion of the inferior oblique is nasal to the inferior rectus muscle. This procedure is indicated on patients with persistent inferior oblique overaction or overelevation in adduction, still with a V pattern exotropia in up gaze and hypertropia in the field of action of the inferior oblique or hypertropia in primary position with inferior oblique overaction, and is considered a procedure that causes a more significant weakening of the inferior oblique compared to an temporal anterior transposition of the inferior oblique. Some authors have indicated some advantages, including less incidence of anti-elevation syndrome caused by the nasal transposition of the inferior oblique. The nasal myectomy is a procedure that is performed when the inferior oblique has already been anteriorly transposed and is still overacting. The nasal myectomy cuts the fibers of the inferior oblique that are directed to the insertion on the nasal orbit. At this point, the inferior oblique will be inserted on the eye by the scleral insertion and by the fibrovascular bundle that correspond to the innervation and the ancillary origin to the innervation to the inferior oblique. So if you perform a nasal myectomy, in theory, your inferior oblique muscle is running on the path of the inferior rectus muscle. It will weaken the elevation of the inferior oblique more than any of the other procedures. And last, denervation and extirpation. This is a procedure that Dr. Caleb Gonzalez published and demonstrated that was successful in treating patients with persistent inferior oblique overaction despite other weakening procedures. It is, in theory, an irreversible procedure. One of the points that the surgeon must be cautious about is that denervating the inferior oblique may also cause an denervation of the pupil with persistent mydriasis. Periosteal fixation was a procedure that was described by the group of UCLA, conducted by Dr. Rosenbaum, and it was a procedure when everything else didn't work, trying to weaken the inferior oblique. It caused a profound weakening, but in theory is reversible. The biggest concern when performing this procedure is opening the septum and the exposure of the orbital fat that can cause a fibrosis syndrome with restrictive strabismus. So, among the complications of weakening the inferior oblique, anti-elevation is one of the most frequent ones, and the clinical presentation of this complication is a limited elevation in abduction. So when a patient has an anti-elevation, the eye that is affected cannot elevate in abduction. The anti-elevation is an innervational phenomenon. In other words, the forced duction test should be negative, except if the inferior oblique was resected or the surgery had caused restriction to elevation by scar tissue formation. The forced duction test in an anti-elevation syndrome is negative because the new position of the inferior oblique causes a limited elevation when the patient tries to look up, but the inferior oblique is holding the eye down. The patient with anti-elevation cannot elevate the eye in abduction, which corresponds to the field of action of the ipsilateral superior rectus muscle. The contralateral yoke muscle for the superior rectus is the inferior oblique. So the patients with an anti-elevation syndrome will frequently present with a contralateral inferior oblique over elevation in adduction. Other complications associated with inferior oblique muscle surgery include hypotropia, limitation to elevation with hypotropia and upgaze, eyelid asymmetry, which is more important when performing unilateral surgery, especially unilateral anterior transposition. Is being demonstrated by Dr. Kushner on a previous publication, where he found that an anterior transposition of the inferior oblique displaces the inferior lid anteriorly and up, and it creates a shape where the when the lower lid bulges up and anteriorly. We're going to move to superior oblique muscle surgery. And the superior oblique has several characteristics that are very important when considering surgery. Number one, the superior oblique fibers are running longitudinally, and these fibers extend to insert on the sclera with a special characteristics. Dr. Helveston, on an article published by him, demonstrated that the superior oblique tendon fibers are moving on a telescopic fashion, and those central fibers of the tendon have the maximal excursion from the apex on the orbit to the insertion on the sclera. So it's very likely that those fibers are the most important in terms of tension, tightness, or weakness. The superior oblique have been also divided on fibers that are more torsional, which are the anterior fibers, and fibers that are more horizontal and vertical, that are the posterior fibers. Dr. Alan Scott, on a computer model study in 1975, demonstrated that all fibers have torsional, horizontal, and vertical function. It depends if the patient is looking in the primary position or in down gaze, corresponding to the field of action of the superior oblique, that the forces translate to the anterior fibers for torsion or to the posterior fibers for vertical and horizontal action. Dr. Helveston described some very important characteristics of the superior oblique tendon. There are patients that are born with anomalous tendon, and the most common condition is a lax tendon. And these patients with superior oblique underaction will have a tendon that is known as a redundant or lax, and when the exaggerated force adduction test of the superior oblique is performed, the tendon is floppy. And compared to the contralateral normal eye, assuming that is unilateral, there's going to be a marked difference on the exaggerated force adduction test for the superior oblique, as described by Guyton and modified by Plager. There are also some insertional abnormalities on the superior oblique tendon. Either the tendon is not inserted on the sclera, is inserted on the tendons, or could be inserted nasal to the superior rectus muscle. And finally, the superior oblique tendon may be absent even if the coronal MRI scan shows some belly posterior in the orbit. The tendon may not be present, so there's no insertion of the superior oblique on the sclera. There are other characteristics that have been found on MRI scan as anomalous innervation of the superior oblique muscle. The exaggerated force adduction test I was referring to is a test where the eye is rotated, it retropulsed, and is moved in subadduction. And the eye is rotated back and forth on a torsional movements, created tension on the superior oblique tendon. When the tendon is normal, the surgeon should feel the tendon touching the sclera and making a pass. But when the tendon is loose or lax or redundant, there's not such a feeling. If a patient presents with an exaggerated force adduction test that shows a lax tendon, exploration of the superior oblique is recommended. And if the superior oblique is lax, a superior oblique strengthening procedure, such as superior oblique tuck, is recommended. The superior oblique surgical procedures can be divided on weakening procedures and strengthening procedures. And it's really the indication by clinical examination that will determine what procedure to perform. If you have a patient with an A pattern or limited elevation in adduction, a patient with Brown syndrome, inferior oblique weakness, a patient with an A pattern dissociated vertical deviation, and the A pattern is larger than 10 prism diopters, especially with an incomitance where the patient has more DVD in AB adduction, weakening the superior oblique may be indicated. And also for patients with intorsion. Strengthening procedures are recommended in patients with classic superior oblique palsy, patients with concomitant hypertrophy, worse in adduction, especially in the field of action of the affected superior oblique, or in patients with extorsion as the most important manifestation. Also, the superior oblique procedures may be divided on uncontrolled and controlled weakening procedures. This differentiation is important because uncontrolled procedures are procedures where the final position of the tendon is unknown. These are procedures that are usually performed for patients with poor or non-fusional potential, and these are procedures that will have a more significant correction of the hypertrophy in the primary position and in the field of action of the superior oblique. Correction. These are procedures that are performed to correct a more significant hypotrophy in the field of action of the superior oblique and in adduction. For example, patients with downshoot in adduction. But as a complication of this procedure, it's more common to create a secondary superior oblique palsy. Graded weakening procedures or controlled weakening procedures are those procedures that are performed just to weaken the more posterior fibers, for example, in patients that have excellent fusional potential but had a minor downshoot in adduction or have a small A pattern exotropia or mild limitation to elevation in adduction. So this procedure of a posterior tenectomy will not weaken the anterior fibers and will decrease the chances of creating a secondary superior oblique palsy with extorsion. Also, the recession of the superior oblique following the path of the superior oblique tendon. A split lengthening C-plasty procedure, the spacer that can be performed using silicone spacers or suture spacers, and finally, the anterior tenectomy that can be performed for patients with intorsion causing diplopia but no vertical misalignment. I personally recommend performing controlled surgical procedures when the patient has torsional strabismus to avoid a secondary vertical misalignment, or patients with vertical strabismus to prevent a torsional strabismus. Superior oblique strengthening procedures. We mentioned that the exaggerated force adduction test is very important, and the indication for a superior oblique tuck include a lax tendon in a patient that has a vertical deviation characterized by a hypertrophy in the primary position of 10 prism diopters or more, in the primary position with significant hypertropia in the field of action of the superior oblique, patients who have a superior oblique interaction between -2 and -3, mild inferior oblique overaction is desirable because if the procedure is performed in a patient who have no over-elevation in adduction, the surgery may result in a significant under-elevation in adduction or a secondary Brown syndrome. It is also a procedure that is performed when the patient have, as part of the deviation, excyclotropic deviation or extortion. And this video, kindly shared by Dr. Noemi Rosero from Barcelona, depicts a surgical technique to perform a superior oblique tucking. You can use absorbable and non-absorbable sutures. You can also use an instrument called the superior oblique tucker that can, in millimeters, help you to determine the amount of tucking. I personally do this technique where I use 2 sutures, one on each side of the superior oblique, to create the tuck. My recommendation when you do a tuck is the following. If you want to know if a superior oblique tuck is tight or not, remove the eyelid speculum, remove any traction sutures, and repeat the forced duction test. This is important. You have to do it before and during the procedure. Take the eye with a forceps at the 6 o'clock limbus. Take the eye in adduction rotation, straight, and elevate the eye. And you elevate the eye to know preoperatively how far up you can bring the eye. After you perform a superior oblique tuck, the ideal restriction should happen when the 6 o'clock limbus in adduction pass the medial canthus. If you cannot pass the medial canthus, the superior oblique tuck is too tight, and I recommend you loosen the tuck. But if you can bring the eye in elevation adduction with no restriction, I recommend you reposition the sutures or put a second set of sutures, creating a larger amount of tuck in millimeters. The complications of the superior oblique tuck, the most common one, is the inability to elevate the eye in adduction, also known as a secondary Brown syndrome. Most of the patients with mild Brown syndrome secondary to superior oblique tuck get better as the suture loosen up and the tendon loosen up. But if the patient has a significant initial overcorrection, it's ideal to take the patient back to the operating room within a few days and reposition the sutures to prevent permanent fibrosis and permanent Brown syndrome. A superior oblique reposition is indicated on patients who have an anomalous insertion of the superior oblique tendon, as described by Dr. Helveston, that is present in about 19-20% of the patients with congenital superior oblique tendon anomalies. The most common and important is the nasal insertion. And in the paper by Dr. Helveston, he named this as the class 2 superior oblique tendon anomaly. And these patients have an insertion on the nasal side of the superior rectus. What Dr. Helveston recommended was a reposition of the superior oblique following the path of the superior oblique tendon towards the normal scleral insertion. However, if the superior oblique is tight, it may not reach the temporal side of the superior rectus. The most important is that the patients that have superior oblique nasal insertion, when the tendon is inserted at the level of the superior oblique, because the new insertion is anterior to the equator, will present with a limited down gaze. And because the superior oblique at this location is not abducting the eye, also becomes an anti-abductor, and it may cause an esotropia in down gaze with hypertropia in down gaze. This picture depicts a superior oblique that is inserted nasal to the superior rectus. On this picture, you see that the superior rectus muscle is being isolated on a muscle hook. The hook is directed from nasal to temporal, and next to the superior rectus insertion is the superior oblique insertion. This patient underwent a disinsertion of the superior oblique with a reposition posterior to the equator, following the normal path of the superior oblique tendon. Superior oblique weakening procedures. One of the most common procedures performed is the superior oblique elongation. And there are different procedures where the patient can undergo a silicone spacer elongation, a suture spacer elongation, as is depicted on these pictures. This is the superior oblique tendon. A suture is placed on the superior oblique. The superior oblique is transected and is elongated. This procedure is performed for patients with significant superior oblique under elevation in adduction. It's also indicated in patients with Brown syndrome, also in patients with significant overdepression in adduction, as those with the downshoot in adduction and limited elevation and hypotropia in the primary position. Another procedure is the superior oblique recession. And again, this video is a courtesy of Dr. Rosello from Barcelona. This procedure depicts the superior oblique tendon being isolated on a suture, and the muscle is reinserted on the sclera following the path, always considering two things that are very important in the anatomy of the superior oblique. Number one, the attachment between the superior oblique and the superior rectus, the frenulum. The frenulum needs to be dissected using blunt dissection to allow the superior oblique tendon to run nasally under the superior rectus muscle. And second, when the superior oblique tendon reaches the equator and is anterior to the equator, it becomes an antidepressor. And if the superior oblique tendon is also anterior to the equator, it also loses some of the abducting forces. Posterior tenectomy is a surgery that is performed to manage patients with vertical misalignment, hypotropias in the field of action of the superior oblique, or patients with a small angle exotropias in down gaze, A patterns, or patients with dissociated vertical deviations that have less than 10 prism diopters of A pattern. The posterior tenectomy respects the anterior fibers of the superior oblique to prevent torsional diplopia. Torsional surgery on the superior oblique is performed for patients who have extorsion or intorsion. For those patients who have extorsion and already had a superior oblique tuck, or the patient have a very small deviation in the primary position that doesn't warrant doing a full tuck procedure or any other vertical muscle surgery, or patients with bilateral superior oblique palsy who have a large amount of extorsion. The intorsional surgery is recommended for patients who are unable to fuse a vertical misalignment or a non-vertical misalignment in the primary position. The most common procedure performed is the technique of Harada and Ito, or an anterior lateral transposition of the anterior fibers, considered as the 1/3 of the fibers of the superior oblique tendon. And this video depicts the surgical technique. The superior rectus is being isolated on a muscle hook. The superior oblique is isolated on a muscle hook now, with careful identification of the entire superior oblique tendon, including the most posterior fibers. Only the anterior fibers will be operated on. It's very important that the entire superior oblique tendon fibers are isolated. And when as you can see on this video, including the most posterior fibers is important. Always remember the vortex veins, similar to the inferior oblique surgery, are very close to this area of the superotemporal quadrant. After the temporal fibers of the superior oblique are isolated, the tendon is split longitudinally between the anterior 1/3 fibers and the posterior 2/3 fibers. And the anterior 1/3 fibers are disinserted from the sclera, and they are transposed, reinserted next to the belly of the lateral rectus muscle, 8 millimeters posterior to the insertion of the lateral rectus muscle. This procedure corrects a significant amount of extortion, about 11 degrees in average of extortion. The group of Iowa demonstrated that a Harada-Ito procedure has a vertical effect in the primary position that corresponds to the preoperative vertical misalignment. But it's important to know that if the patient has a large amount of vertical misalignment, the Harada-Ito procedure is not indicated. A superior oblique tuck is perhaps the procedure of choice. It's also very important to know that patients undergoing Harada-Ito procedure have surgery that is not stable for several months, and perhaps it's desirable to create a secondary intorsion following the technique. The technique of Harada-Ito has been modified, including adjustable suture technique. My recommendation is to always aim for some degree of overcorrection. In a paper by Nishimura Rosenbaum at UCLA, significant regression of the Harada-Ito procedure was seen up to 3 months following the surgery. An alternative to the superior oblique Harada-Ito procedure is the technique of only tightening the anterior fibers, and there are different techniques to achieve this. There is a technique that was described in Germany where the anterior fibers are advanced temporally without disinserting them from the sclera. The procedure is very effective, but may cause Brown syndrome because it can cause also some tension on the posterior fibers of the superior oblique. An alternative technique that we had the opportunity to publish is the superior oblique anterior tuck, where the anterior fibers are similar to the Harada-Ito, separated from the posterior fibers. But instead of disinserting them from the sclera and transposing them temporally, only the anterior fibers are tucked using an absorbable or non-absorbable suture. we have found that this procedure, even though it's not as aggressive in correcting extorsion as is seen in patients with the Harada-Ito procedure, it is more stable, including minor changes between early and late postoperative follow-ups. And this procedure is correcting approximately 1 to 2 degrees of extorsion per millimeter of TOC. The superior oblique anterior tenectomy is a procedure that we recommend for patients that are unable to fuse in torsion. This procedure is also being performed to treat patients that have dissociated vertical deviation with significant head tilt. Dr. Prieto Diaz, who was the first author describing the posterior tenectomy of the superior oblique and the anterior tenectomy of the superior oblique, first recommended the anterior tenectomy to treat patients that he described as direct head tilt. These were patients that were tilting the head towards the affected eye to decrease the vertical misalignment. And those patients were doing that because of encyclorotation of the affected eye. An anterior tenectomy is a procedure that can help in correcting the torsion with or without surgery on other vertical rectus muscles. And finally, for the management of the Brown syndrome, the weakening of the superior oblique tendon. The most important variables that we consider when treating patients with Brown syndrome are the preoperative deviation in the primary position and how tight the superior oblique tendon is. A nasal tenotomy can correct 10 to 14 prism diopters of vertical misalignment in the primary position. It is also important to remember that several authors, including Velez, have published what is called the greater tenotomies of the superior oblique. Closer to the insertion on the temporal side, the greater tenotomies demonstrate a much weaker effect. When the incisions are made away from the insertion on the sclera, that tenotomies increase the effect in the primary position. The nasal spacers, depending on the length, can correct up to 30 prism diopters of hypotropia. And in patients with small deviations in the primary position and Brown syndrome, an alternative is weakening the posterior fibers because those fibers will not modify the torsional component, but those fibers, if the posterior tenectomy includes a wide tenectomy that will also remove the central fibers, will decrease the tension based on the findings by Dr. Helveston that those central fibers of the superior oblique tendon have the maximum excursion from the orbital apex to the scleral insertion. This is a patient with Brown syndrome, limited elevation of the right eye in A deduction, but very small downshoot in A deduction or hypotropy in the primary position, who underwent a posterior tenectomy of the superior oblique and the right eye. Postoperatively, the patient had excellent elevation in A deduction. Now, the most common problem following a surgery for Brown syndrome is the residual Brown syndrome, and is frequently seen after nasal tenotomies or even after graded procedures. As you can see, nasal tenotomies have less incidence of under elevation in A deduction because it's a significant weakening procedure of the superior oblique tendon away from the scleral insertion. and this effect is more significant than any of the other procedures. In greater procedures, the under elevation in A deduction is more significant, especially if it's not indicated for patients with small deviations in the primary position. This is a kid that had a significant torticollis and a very severe left eye limitation to elevation caused by a severe Brown syndrome, also affecting the primary position and even the AB adduction. The patient underwent a free nasal tenotomy of the superior oblique tendon. His head posture was completely corrected, and the bottom picture on your right demonstrates an improvement in elevation in A deduction. This procedure that I'm about to present to you, in my opinion, has a significant value in the management of patients with congenital Brown syndrome, but also in patients with acquired Brown syndrome. This procedure was first described by a Brazilian author, Ortha Barbosa. And this procedure consists of a thinning of the superior oblique tendon. I'm going to present the procedure, and I'm going to remark the important steps of when performing this surgery in patients with Brown syndrome. The first step is to do an exaggerated forced adduction test in elevation in A deduction. As you can see on this, I'm trying to elevate the eye in A deduction and try to improve the elevation. If I can improve the elevation in A deduction, this has a meaning that thick portion of the superior oblique tendon that is posterior to the trochlea, that cannot pass through the trochlea in an attempted elevation in A deduction, is now anterior to the trochlea, thanks to the exaggerated forced adduction test in elevation. If you have that from this procedure, then you can proceed with a superior oblique thinning procedure. And you can see here that now the elevation is normal. So a supero-temporal incision is created, extended nasally. The superior rectus muscle is exposed. It would be ideal to expose the superior oblique tendon on the temporal side of the superior rectus, to extend it nasally. And this is important because all the fibers will be captured much easier temporally than nasally, avoiding the tendons. Here you can see the superior oblique tendon now on the nasal side of the superior rectus muscle. And because the exaggerated forced adduction test is being already done, a second muscle hook is placed in between the two nasal portions of the superior rectus muscle and the trochlea. Now you have two muscle hooks running between the superior oblique tendon. One is next to the superior rectus, and the other one is next to the trochlea, exposing the pearl-thickened tissue around the superior oblique tendon. This tissue is dissected and is removed. And this tissue is removed until the forced adduction test is persistently negative at the end of the surgery, or until no more pearl-thickened tissue is seen. It is ideal to perform this procedure under the microscope to visualize the superior oblique tendon fibers better, to avoid any excision of superior oblique tendon fibers that may cause superior oblique palsy. Going back to this superior oblique tendon thinning, to me, it is important when managing patients with congenital Brown syndrome. If you do the forced adduction in elevation is exaggerated and you cannot release the tension and the restriction, you're probably not having a patient with a normal length but thick superior oblique tendon. What you probably have is a short superior oblique tendon. And in those patients, I prefer to do a superior oblique nasal spacer procedure or a superior oblique recession. But if I have a patient with a congenital superior oblique correction, a congenital Brown syndrome, or a patient with an acquired Brown syndrome that will not have a short tendon, but instead probably a thickening of the superior oblique caused by an inflammatory condition, an infection, and that is not traumatic, that patient will benefit for doing a superior oblique tendon thinning if the force adduction test becomes negative intraoperatively. Weakening the superior oblique can cause a superior oblique palsy. This is a patient with Brown syndrome, and you can see his limitation to elevation in adduction that is very severe. This patient underwent surgery for the correction of the Brown syndrome. Postoperatively, you can now see that the patient has developed a right head tilt. Even though the elevation in adduction is better, there is also under depression in adduction. So it is very important when operated patients with Brown syndrome to prevent a superior oblique palsy. And if you are considering doing a significant weakening on the superior oblique, for example, a nasal tenotomy, always think that your patient may develop a superior oblique palsy that may need to be treated by weakening the ipsilateral inferior oblique muscle. I want to thank Dr. Kushner and the organizers for inviting me to present this lecture.
Thank you, Federico. That was so comprehensive, so clear, and so thorough. I think we should relabel this talk Everything You Ever Need to Know About the Oblique Muscles. That was really wonderful. I'd like to just make a few comments. I do have one question. As would be expected with a course like this, there is some overlap between topics. There's a separate lecture on vertical strabismus. There's one on paralytic strabismus. So some things will be repeated. The index case of the anti-elevation syndrome appears in video in the lecture in this course on vertical strabismus, as does the original video that Dave Guyton, who generously allowed us to use, when he demonstrated the exaggerated force adduction test. That's also on the vertical strabismus lecture, in the vertical strabismus lecture. I always like the aphorism, there are many roads that lead to orthophoria. Viewers may observe that there will be somewhat different approaches to, let's say, treatment of superior oblique palsy given from one lecture to the other. That is not to say one is necessarily better or worse than the other. There are different schemas that work well, and I'd encourage viewers to find the one that they're most comfortable with, and rest assured that people with experience have good results with that approach. I'd also say I was interested to see in the video you showed of the superior oblique tuck that the surgeon who was doing it did not use a tucker. And I think that's important to emphasize. I have some colleagues who'll say, well, I don't have that much occasion to do a tuck, and we don't have a tucker in my hospital. I find it actually easy just to pull the tendon up on a hook, sometimes use two hemostats to slide down and clamp the tendon and put sutures behind them, and it's less bulky than a tucker. We have a tucker in my hospital. I never use it. The one question I had for you, Federico, in the Z tenotomy at the insertion of the inferior oblique muscle that you presented, do you think it makes a difference if you make the cut closest to the insertion from the anterior side versus the posterior side, if you want to selectively get torsional correction versus vertical correction?
May I cut you on that? Is that okay if I cut you? Okay, I want to tell you, 4 days ago, I did this procedure, and yesterday I repeated on a different patient. And on Monday, I told our fellow we were going to do the first incision on the anterior fibers because of the Kushner inferior oblique torsional procedure. Oh. And that was, so the fellow asked me, so what do you mean by that? He said, in my head, if I am treating a patient that, like that patient on Monday, complains of lots of torsion, but has a small vertical, I'd rather start by weakening the torsional fibers because I think it's where you're going to give more tension. That patient, I started anterior, but the patient yesterday had no torsion. He just had a vertical alignment that was bothering him when he was bowling. And he only had 3 in the primary position. And I told the fellow, today we're going to start on the posterior fibers. And because the patient has only 3, we're going to do only 3 incisions. And I started on the posterior fibers. So I don't have enough patients to say, this is my casuistic and this is how I see it. But in my brain, that's how I do it.
Okay. Thank you. That makes sense to me. That's a good answer. Well, again, Federico, I'd like to thank you very, very much for a wonderful lecture. And viewers, I thank you for your attention. And if you enjoyed this, which I anticipate you did, please tune in to all the other lectures in this series. And with that, I will wish you all a good morning, good afternoon, good evening, depending what part of the world you're in and what time of day you're viewing this. Till next time.
In bringing you this video course, there are many thank yous. Thank you for viewing the video course on strabismus. We hope you found it stimulating and educational, and that you share its insight with others. We at One World, One Vision extend our heartfelt thanks to the lecturers who shared their years of study to make the video course worthwhile. And of course, to Bert Kushner for taking on the burden, happily we hope, of development and moderating. We also thank the Board of Directors for their continued guidance. We thank our donors for their financial support that made this video course possible. An enormous thank you to the video team of Sweet Sadie for their extraordinary efforts to make the course both visually and auditorially extraordinary, and for their technical guidance of the lecturers. Thank you, Rachel, Tim, Eddie, and Bill. If you are interested in learning more about what we do, go to our website, www.oneworldonevision.org. And finally, if you have comments or thoughts or ideas, you can email me at owov2020@gmail.com. Goodbye.